we'll move on to our next presenters, who will be Nicole Millis. You heard in the earlier session how important the patient voice is, and nowhere in rare diseases do we have a patient voice as loud and clear as Nicole. Nicole is the CEO of Rare Voices Australia. And also we'll be hearing from Tiong Tan and Katrina Bell around a patient story and how multi-omics has been brought to bear to get an answer. But first, while they're coming up to the stage, we have a video.
Everyone loves a superhero, right? This is a story about my Uncle Bruce and his superpowers. Bruce has a rare ability. Not many people have it. The power to sprinkle joy wherever he goes. In our family, Bruce is the CJO, otherwise known as the Chief Joy Officer. Bruce finds joy in lots of things, but especially trains, boats, helicopters, really anything that moves. As well as his family, friends, kids playing, and most of all, ABBA. My uncle even inspired the establishment of the Bruce Lefroy Centre at the Murdoch Children's Research Institute. Come on, it doesn't get much more Bruce Wayne than that, does it? What a superhero. Uncle Bruce has come today to meet the directors and Erica, who has been helped by the research done at the Bruce Lefroy Centre.
We do research that aims to find problems in the clinic and solve them and make a difference for people. So we find potential treatments and test them in people with genetic conditions.
I worked in the lab. I didn't have any patient contact at all. Now I've been able to interact with people like Bruce, and it's really opened my eyes to what drives families with people with genetic conditions.
I can see what you mean about Chief Joy Officer. I'm sure you are the superhero of your family. I was diagnosed with Friedreich's ataxia when I was around 15. There's only a couple of hundred of other people in Australia which are going through the same thing. It can feel a little bit isolating. So with the research and everything, the fact there's such a big team behind it again, it's been validating, I guess, that I'm not by myself.
It took 35 years for Bruce to receive his diagnosis. Young people today are diagnosed within a few days and have better access to care for themselves and their families. Move over, Bruce Wayne. This is Bruce Lefroy, my uncle and our hero.
Wasn't that a great video? And it really, Martin and Paul both highlighted how the patients and their families are what drive us to be relentless in our efforts to try and get answers for them. And so I think it's really very appropriate that the next person we call up to the stage is Nicole Millis.
Thanks, John, and thanks to all of you for inviting me. I know I'm one of the very few outsiders, so I'm very privileged to be here. But I promise I'm not quite as scary as John made me sound. What did he say? Loud and scary or something. Anyway, I promise I'm not. So I guess I wear many different rare disease hats. And I've just put a few of them up there on the slide. But primarily I was asked today because I am a member of the RD Now Consumer Engagement Committee. And I'm also the CEO of Rare Voices Australia, which is the national peak body for Australians living with a rare disease. And I guess if we describe what we do at Rare Voices, or RVA, our main goal is to influence policy through systemic advocacy. For the RD Now Consumer Engagement Committee, I think that there have been many learnings that have informed the project, of course, for both, but the learnings are for both the MCRI team and the consumer members. And I think those learnings centre around things such as communication, transparency, connections, and pathways. And I think the process of that group has really encouraged a greater understanding from all. So it's hard because we don't measure rare disease very well in this country, but many say there are about 7,000 different rare diseases. And so clinically, there's many differences between all these different diseases or disorders, but also even within the same disease or disorder, there is a very high level of heterogeneity. So despite this variation, what always strikes me and my colleagues at RVA is the high level of commonalities between all those different conditions. Particularly when you look not just for commonalities within diseases, but perhaps more impactfully, the commonalities around the impacts of what that means of having a rare disease. Much is often said about the diagnostic odyssey around experienced in rare disease. But that rarity itself also has an impact regarding lack of awareness. There's limited care and support options. There's often a lack of research, and there's most definitely poor data collection and use. And what the flow-on effects of that, and we've heard it even in the video just before, can lead to isolation. And I often say that I think the most pervasive thing for rare disease is uncertainty. And the impact of uncertainty is not just felt by individuals or families living with a rare disease, but the uncertainty that relates to the systems and the broader rare disease sector that responds to them. So those that know me know that this document is very close to my heart. There is a National Strategic Action Plan for rare diseases, and this is the Australian government's really first coordinated policy approach to rare diseases. It was very much developed by the rare disease sector for the rare disease sector. RVA led this collaborative development, which was developed through multi-stakeholder consultation. It is very much evidence-based, and very much the approach was co-design. The foundational principles for this policy are person-centred, equity of access, and sustainable systems and workforce. There are 3 pillars: awareness and education, care and support, and research and data. It provides a framework and a policy direction from which the whole sector, and that includes everyone in this room, that can advocate on issues that are important to them. You'll see here, so I've pulled out just an excerpt of the action plan and a fairly high level, summary of each of the pillars. And you can see there, hopefully, it's great, it's a big screen, so hopefully you can see the key priorities under each pillar. But what we know is that the strongest approaches, the most effective responses to rare disease, are those that respond to elements under all 3 of those pillars. And RD now does this. Through the promoting and contributing to awareness and education around rare disease within MCRI and beyond. And as a diagnostic response that is so critical to leading to optimum care and support and the development of pathways to research and data. Here is another excerpt from the action plan. Themes for achieving progress. And you can see there's some key words that I've no doubt that you've already heard throughout many of the presentations today. Around national leadership, coordination and consistency. The need to prioritise the building of knowledge, sustainable expertise, the importance of a person-centred and co-design approach, and that is an active process. It needs to be ongoing. The critical need to better measure rare diseases, workforce, we've already mentioned, collaboration, but importantly those partnerships, which I know that MCRI, they have state, national, international partnerships. And I've already heard it in the short time that I've been here today, the need to progress early implementation wherever possible. So I wanted to share this with you because I think it's always I know often at these things we look at what we can be doing, but I think it's also important for people to take stock and be proud of what they've achieved. And you can see against this criteria around which the action plan, you guys are doing a great job. Thank you.
Thanks, Nicole, for beautifully articulating the sort of national context in which we work. I think it's important for us to remember that rare diseases affect about 1 in 12 people globally. That translates to about 2 million Australians who are living with a rare disease. The cornerstone of any disease, whether it's common or rare, is the diagnosis. That enables access to therapies or clinical trials, connection and support, and reproductive options. We know that rare diseases disproportionately affect children and are often genetic in origin. Yet why is diagnosis so difficult to achieve in children with rare disease? A lot of people talk about this diagnostic odyssey in which it takes approximately 5 to 7 years for each individual with a rare disease to be diagnosed precisely and accurately. Many individuals undergo many investigations repeatedly, seeing specialist after specialist with no diagnosis made. Along comes genomics, and we hear about the promise of genomics, and it's fantastic, and I'm all in. But genomics so far in clinical testing, standard clinical testing, diagnoses approximately 50%. So what do we do with the 50% who are undiagnosed after standard clinical genomic testing? Underpinned by the framework that Nicole has talked about of the National Strategic Action Plan for Rare Diseases, which has been endorsed championed by RVA, but endorsed by the national government, we conceived of this program called RD Now, Rare Diseases Now. And we've taken a three-pronged approach. We want to look at discovery. We want to discover new genes, new mechanisms, new treatments if available for patients with rare disease. We want to engage. We engage with clinicians, researchers, scientists, consumers, and national and international consortia looking into rare disease. We want to translate our discoveries into standard clinical care. We want to aim for precise diagnosis, appropriate care, and available therapies. Each child who enters RD Now gets a bespoke testing strategy. What have we achieved so far? We've enrolled over 200 patients and families, and so far we have already achieved a diagnostic rate of about 50%. So this is 50% on top of the 50% who are already diagnosed through standard clinical testing. I can tell you all the theory that all day, but really, I want to illustrate to you this story, a very recent story of a patient who came through RD Now. Well, came through the Royal Children's Hospital clinics, and then and came through to RD Now. So this is a little boy who is 10 months old, and of course we have consent to share this story. He came because his parents were concerned about developmental delay and low tone, and he had a big head. Some preliminary workup suggested that he had this rare neurodegenerative condition called Canavan disease, but it wasn't certain. So he underwent some genomic testing, but this was inconclusive. We couldn't be sure if he had Canavan disease or not. But this was critical because this is a neurodegenerative condition, and if he was confirmed to have Canavan disease, he would have access to a gene therapy trial, and so time is of the essence. So we offered participation in RD Now, and we enrolled him to get access to advanced frontier diagnostic testing strategies. And with that, I'm going to leave you on a cliffhanger. Over to Katrina to tell you what happened next.
Thanks, Tiong. Today I'd like to try and demystify a little bit what the analysis of sequencing data for rare disease patients actually looks like, using the family that Tiong has just described as an example. Now, this case, from the initial testing, they already knew that this patient had a single hit in the gene of interest that was inherited from the mum, but they needed a second hit for confirmation of a genetic diagnosis. Now, it would be really great if there was just one method that picked up all the different types of genetic changes that can cause disease, but unfortunately that's just not the case. We need a whole variety of different methods, each identifying a different type of genetic change. Now, the first item we do when we receive sequencing data is actually to register it with Archie. Archie is our sequencing management software built within the MCRI Bioinformatics group to organise all the sequencing files as well as the metadata, and also to kick off the different variety of analyses. To give you a frame of reference, the RDNOW project on its own contains over 100 terabytes of data. Therefore, having a system like Archie is essential to streamline the analysis of these files and keep it in an organised and logical and searchable way. Now, the first analysis we did for this family was to look for single base pair changes. This analysis only detected the hit that we already knew that was inherited in mum. There was no second hit, which is what we were after. The next analysis looked for large changes, large segments of DNA duplicated or deleted, but this was also negative. At this point, I have to admit, I was feeling a little disheartened, I won't lie. I went back to the RDNOW team to ask if there was any other genes that I should be looking at, as this was not seeming to pan out. And their response I got from the clinicians was a very clear, no, this is the gene. And I was actually thrilled at this response, even though it actually meant that I was missing something in my analysis. The human genome is 3 billion base pairs long, and they had just told me that I was missing something in only 30,000 base pair region. It's still a large region, but doable, at least in my opinion. So to give you, again, something to think about, it's like if you lost something on a road trip between Melbourne and Perth. And you might feel a little disheartened at that, but then to be told that it was actually within a 30-metre region of road outside your house, I'd go searching. So with some bespoke analysis, which in this case was an extremely manual process, I focused on those 30,000 base pairs. And I identified a 2 kilobase fragment of DNA that was inserted deep within an intron, the non-coding part of the candidate gene. And this was inherited from the dad. Now, usually variants within this region of a gene are tolerated. They don't cause disease. So it wasn't immediately clear we'd actually found our second hit. But there were a few things about it that made this event that made us think it was worth following up. So we did. Now, what we were thinking was that this inserted DNA fragment was disrupting the process of how the mature mRNA of this gene is put together. So the next step was to perform RNA-seq to prove or disprove this theory. Now, of course, this was also challenging to do. We had many attempts that were non-informative. And in the end, we had to get the father to come back in and donate more tissue, as this analysis is tissue-specific. And we were very grateful for his willingness to help, as it was from this additional tissue that we were finally able to prove that that DNA insertion that I told you about actually did disrupt splicing, or how the mature mRNA of this gene was put together, which meant we finally had our genetic diagnosis, a confirmed second hit. Now, this result enabled the family to, as I said, obtain a full genetic diagnosis. And due to that, they were accepted into the clinical trial that they were wanting for their son. Now, the journey for this family is not over, but having a full genetic diagnosis will reduce some of the hurdles that they will face in the future. And it has also enabled family planning, if that's something that they're interested in. Now, this diagnosis just would not have been possible without the varied expertise of many people within the RD Now team and the infrastructure to perform all the different types of analysis that was required, both in the lab and computationally. Now, RD Now's priority is always the families that are enrolled into their program, but it also has another very valuable outcome, and that is to highlight new areas of research. By focusing on these challenging, undiagnosed families, we learn where we need to improve or gain knowledge so that future families with these types of events will be able to receive a timely diagnosis. Now, as a bioinformatician, I actually have a dual role. I'm a member of the RD Now team, but my main role is actually within the MCRI Bioinformatics Methods Group. Now, I've been able to take my experience within RD Now back to the Bioinformatics Group to start working on an additional analysis method, another spoke in that wheel, to help identify all the different identify the specific type of insertion that I spoke about previously in a very systematic way. Ultimately, what this might mean is that families like this one in the future may never have to join a research group to get a genetic diagnosis. And these events potentially could be identified in the initial clinical testing ordered by their clinician. So RD Now ends the diagnostic odyssey for many families, but in addition, it helps us gain knowledge that keeps MCRI at the forefront of genomic testing. Thank you.
Thanks very much. That was really a fabulous example of how bringing these technologies together can yield an answer for families in real time, in a clinically meaningful time. Unfortunately, we don't have time for questions, but I'm sure our speakers would be very happy to take questions after this session. And so I'll thank you, Nicole, Tiong, and Kat, for your great presentations and for contributing to this session. And I'll hand over next to Enzo, who's going to blitz us with stem cells.